All right, terrific. Well, good morning, everybody, or afternoon if we've got anyone in other time zones. My name is Ken Rubin. I'm the executive director of the BPM Plus Health community, and this is our kind of community overview introduction. I like to call it the on-ramp. I expect a modest-sized crowd today, not too big. So I'm happy to take questions as we go. The purpose of this particular session is to acclimate you with the BPM community and how we operate, the principles, and really what we're all about. And the reason that we do this as the first session is this week is our semi-annual workshop. We do have quarterly working meetings and sessions, but every 6 months we do a bit more of a showcase plenary type discussion and sessions, and that's what happens in March and September. So by having this as the first session, we'll be able to give you the context and acclimation to the community and hopefully allow you to better understand and engage with the content for the remainder of the week. So my hope out of today's session is to familiarize you with what's available within the community, a little bit about how we were formed, how we're structured, how we operate, and from which you can make some decisions about whether you want to continue to engage with us. We would love to see that. So if you have a question, I'll encourage you to go off mute and go ahead and raise that. I'll try to pause after each slide to give the opportunity. And let's go ahead and jump in. All right, so let me start with what does interoperability look like today? And for those that are well versed in the health interoperability space, forgive me, we have full spectrum of attendees. So I like to think about interoperability, and I should mention that I'm an enterprise architect by background. I've been in the healthcare space for about 20 years and have spent most of that time in industry. Doing enterprise architecture and solution architecture, and heavily involved in the standards community for that time. Spent a period of time in the government with the US as part of the Veterans Health Administration. And now I'm a research associate at the University of Utah and advising multiple different kind of nonprofit organizations around interoperability matters. So this is to some extent my lane. So I like to think about interoperability in three facets, and there's all sorts of different ways to divide this problem. One that I find useful is the idea of data interoperability, knowledge interoperability, and process interoperability. And there are other models, other ways to slice things, but I find this one really useful. And the reason I like this separation is when you look across the landscape today of what's happening around health interoperability, the focus is predominantly in the data space. And if you were to talk to 10 people about what interoperability means, my bet is that at least 8 of them would talk about data exchange and data meaning and semantics and that kind of a thing. And the laundry list of acronyms over on the left here, those are examples. These are all real projects or real initiatives or standards groups, Argonaut, CDA, CCDA, CCR, et cetera. And each of them has initiatives, projects, activities, standards under them. And they're all a piece of this puzzle, but all associated with the data side of things. And the reason I bring this up is interoperability isn't all about data. And if I leave you with nothing else today, if I've convinced you that the interoperability lens is broader than data, I think this will have been a success. So there's huge attention, focus, and money going into the data interoperability space, but data exchange isn't enough. So that brings us to the idea of knowledge interoperability. So what do I mean by knowledge? So let's take, I'll pick on clinical decision support as an example. And I should mention that my background has been in the provider space. So I tend to focus on direct care and institutions that provide direct care. Everything that I'm talking about doesn't apply exclusively to direct care, but that will be my set of examples based on past experience. So forgive me for that. So when you look at decision support, and what I mean by clinical decision support is the idea of surfacing, medical knowledge and insights at the point of care. So I've got a doctor, in front of a patient, or it could be another provider in front of a patient. They're entering in or reviewing lab results or some sort of physical exam observations, and the computer system could throw a a trigger. So it's based upon this situation, and the readings or results for a particular patient. How do we apply that against what we know about medicine to sift through all that stuff and say, at this point in time for this patient, based upon these numbers, here's something that's relevant and appropriate for the caregiver to consider. And that's what we mean about knowledge interoperability. So it's not enough to know that's out there in the body of knowledge of medicine. How do we actually bring that into our systems and make that actionable and active? And some of the specifications that are cited there, Smart on Fire, the modeling clinical biomedical knowledge, MCBK, and some of these other activities are all kind of in that knowledge surfacing space. And the reason I set this context around BPM is our work is in the process interoperability space. So why is that relevant? One of the challenges faced today, and while I'll speak a bit to the US, and this is absolutely true globally. You run into, every time you change tiers of care, when you change settings of care, there's an opportunity for something to fail, for us to miss a handoff, for us to lose fidelity on a patient, for us to stop a current course of action for that patient and potentially not pick it up at the next step in that patient's journey. And the idea of process interoperability is to allow the clinical activities, those processes, that care pathway in support of maybe it's a chronic condition, to follow the patient through their journey. So let's say you've got a patient that goes in for an inpatient surgery. They overnight in the hospital, they're discharged to a long-term care facility. They spend a few weeks at a long-term care, and then they're released to the home for home care. How do those activity steps relating to their care follow the patient across that journey? It's hard enough if all of those locations, to save the home, are part of one health institution. But in the US, that's certainly not a guarantee. They could be different health systems or health delivery systems. And the idea of having standards and ways to have the processes follow the patient through that journey is critically important to outcomes and quality improvement. Moreover, all of these are moving targets. So you've got your clinical specialties coming out with new guidance all the time. How do we get that into our IT? And how do we replace what's currently happening with the new best practice and make that actionable so that our systems support that? And that's really what BPM is all about. So let me pause for a second. Any comments so far? Agree, disagree? For those just joining, we do have a fairly intimate crowd, so I'm happy to take questions as we go. Okay. Let's move on. So let's spend just a second on data interoperability, since this is really the context where most people are kind of coming at this discipline. So you've got data elements, which is some sort of data of interest. We've got a lab value or a systolic reading, diastolic reading, and so on. And we capture that data element, but that number alone, that value alone, isn't enough for us to interoperate, right? So for us to have more insight, it's not just a value, but we need to know something about that, and that's where terminology fits in. So the idea of having, coding systems, medical vocabularies, et cetera, that start to relate. So when I use the character string MI, I know that in the context of registration, that means Michigan because it's a state code in the US, or it means myocardial infarction because it's an observation and we're using a different terminology, et cetera. So terminology starts to add this underpinning layer of meaning underneath the data elements. And that gets us to the third column, which is ultimately about this shareable, consistent understanding and representation over systems and across time. So at a given point in time, I know what that thing meant. So pre-hypertensive, let's just use that as an example. The definition, the value for pre-hypertension has changed over time. So today, what we would consider pre-hypertensive in the old days might have been considered normal or might have been considered hypertensive. I'm not a clinician, so if my clinical examples are off, please forgive me. So that's an example of kind of this interoperability spectrum. So how does this relate to BPM and why are we here? So the problem is that health processes and best practices are changing over time. I kind of alluded to this before. So you've got studies impacting what we know about medicine. That's affecting the best practices. Those best practices get documented. Those documents become care pathways. Those care pathways need to be ingested into healthcare delivery organizations that need to put them into clinical practice, measure them, test the efficacy, all those kinds of things. But right now, if you've seen one, you've seen one. So every specialty documents their best practices their own way. There isn't a common language for expressing those things. They're expressed in natural language. So when you want to put that into IT, you have to have this interpretive step. What is said in natural language? What does that mean in terms of the IT for order sets and so on? And that becomes very difficult because not only are the institutions having to consider each different best practice independently, that makes it very difficult to understand, to comprehend, to implement. It's costly. It creates opportunities for error, inconsistent interpretation of the guidance, et cetera. So those are all the problems. Let me pause. Does this make sense to folks? Anyone agree or disagree? I'd love to have someone jump in, please. A single taker. Okay. So
hold on, Candace. This is Cheryl from the IAC, and I completely agree. And I was just wondering about do you have or are you working on sort of a vocabulary document? Yeah.
Go ahead. Oh, sorry, I cut you off.
Yeah, a vocabulary document or a technical document that outlines and describes all of the terminologies that are common within this space.
So the short answer is no. We are collaborating with the institutions that do that. So for those that know the space, a name that might be familiar is SNOMED, so the Systematized Nomenclature of Medicine. That's kind of the granddaddy terminology, right? So it's got something like 700,000 unique concepts. It's got like 5 million interconcept relationships. And that's one of something like 130 clinical vocabularies that are in common use today globally, in the terminology space. So we don't need to go reinvent that wheel.
Right.
We want to make sure that the work that we do works with and complements those other activities that are going on. But we're definitely aware of those other activities and doing our best to collaborate with those.
Thank you. I didn't know that. Thank you.
No worries. Good question. Thanks. So so what is the solution? How do we untangle this mess? And we're not purporting to take on the world. We've got our own narrow little lane. But what we're focused on as a community is using industry standard expression languages, graphical languages, based on business process model notation, BPMN, case management model notation, CMMN, and decision model notation, DMN, as kind of the backbone. So these are established languages. They're in use in a bunch of different verticals. And we're trying to foster the convergence around those and other pieces so that we have a common way of expressing these care pathways within the health vertical. And we've been working on this for about 5 years, although the community is only a year old. I'll explain that in a minute. But the idea here is by using these formal, rigorous languages, we can cut a lot of the interpretation ambiguity out of the equation, facilitate speed to market for software supporting these pathways, and allow for more rapid shifting and evolution of these practices as they go to be actually used at a point of care or elsewhere in a business process. So what BPM Plus is, and we'll get into this a bit more in a moment, is it's an open community of practice. We're not a standards body. We're not creating standards. We are leveraging standards, and we're engaging with standards communities to realize these capabilities across the sector, supported by commercial tools, and ultimately focused on advancing this kind of shareable, interoperable processes that we've been talking about. So let me press on. And again, if anyone has any questions, please do. So at a glance, here's kind of how the community is kind of philosophically oriented. So why do this? The best practices are moving fast. The workflow change today is too hard and too expensive. We've talked about all this. The systems today don't really support workflow needs terribly well. And if you've gone to one of the big vendors, and I'm not going to call any vendors out by name, but electronic health record vendors as a market segment, as a category, is an example. They vary in terms of how well they support workflow needs and how flexible they are to adapt to those changes. And we've already mentioned the health industry speaks too many dialects. So this is a community of practice with common language based on open standards. And one of the things that I haven't mentioned here is the object management group. So the OMG is our parent organization. We're a community under the OMG, which basically puts us in a safe set of hands. And there's actually a session at the top of the hour today about the OMG being a consortium of consortia. So in a nutshell, this 30-year nonprofit provides the underpinning to assure kind of an egalitarian community and a level playing field. So that allows competitors to work together toward a common good with a confidence that everyone knows they're getting a fair shake. So that's really what the BPM community is about. How are we doing this? Everything that we are doing is open and transparent, and we're building an egalitarian ecosystem. So our calls are open and public. We'll talk about that. We've got work groups, and I'll tease the work groups and then spend a minute or two on what those are and how those are constructed during the course of this session. We really want to bring in folks that are practitioners and provide an environment for folks to work together. So those could be competing health systems, they could be competing vendors in the market, they could be partners and collaborators that are just working toward a common good. And that's really what the community is about. So my goal is to make everyone equally unhappy, so that people can work together and productively engage and advance this cause, but not skewed toward or away from any one offering. We've deliberately constructed the community so that there are minimum barriers to engagement. All of the assets that the community produces are open and downloadable from the website. That's bpm-plus.org. You can go there now and you can download, all the formal artifacts that have been produced to date. Also, our calls and our work groups, you don't have to be a member to join, and I'll spend a little bit more time amplifying that in a few moments. So that's really what this is about. Just to introduce what the work groups are, and I'll expand on this in a moment. We've got an authoring work group, building these pathways and best practices around this. Process automation and enablement. How do you actually take pathways and make them implementable and make software work and consume these or produce these? Organizational adoption and change management. How do you make these things work in a setting? So in a payer organization, that's trying to do pre-authorization, or in a provider organization that's trying to improve hypertension management across their cohort of patients, et cetera. You've got outreach in the academic front, working with medical schools and informatics programs, as well as fostering professional education in clinical professional societies and healthcare providers and subject experts. And then we've got a work group focused on methodology, which is looking after the core notations themselves. Are they fit for purpose? Do we have any gaps? And in fact, we've identified gaps, and those are in the process of being closed as we speak. So who is this for? It's really full spectrum. Within the community, we've got large organizations, healthcare providers like the VA and Mayo Clinic. We've got small organizations that are, small consultancies and vendors that are bringing new products to market. We've got professional societies. We've got a memoranda of understanding with some of the big players in the industry. We should add IEG to that list. Forgive me, I missed that on this slide. So that's really what the BPM community is kind of, in a nutshell, at a glance, what we're all about. Let me pause for any questions or comments before I move on. So I've mentioned that this is a member-driven community of practice. You've got little photos there of several of the folks that have have been instrumental in getting us to the current state. Part of the reason I wanted to include this slide, even though the bullet points are a little duplicative, is that many of these folks are up for re-election. In the state of the evolution of the community, we formally launched as a managed community of practice in September 2019, so a little over a year ago. And one of the challenges that we had is we wanted to stand up a new community, and we wanted to maintain this openness and transparency, but we also needed to get this thing off the ground. And one of the challenges to that is holding open elections on day one of a new community is very high risk. So what we did is we recruited in folks that we knew had an interest in the space to lead the work groups on an interim basis for a year, a little over a year, to kind of get us off the ground. But we also take the commitment to openness and transparency very seriously. So it took us a year to kind of get our feet under us. And the timing is very fortuitous because right now, this week, we're opening up the co-chair elections. And many of these folks are standing for an elected position. In fact, most of the folks that are standing for elected positions were the interim chairs before. But the fact is now it will be a community decision on who the leadership will be, and that's the model moving forward. So we're very excited to kind of be hitting that milestone. It's a big one for us, and I think it's setting the stage for this openness and community management that we committed to. So just a little bit more on the different work groups. The authoring work group is about how do I create these pathways or these workflows. So I should note that the community, the BPM community, is not in itself creating care pathways. We're not going to develop a hypertension protocol. We're not going to develop a cancer care protocol. That's for the member organizations to decide. We don't take a position on the IP for the pathways. All we are doing is defining what a quote unquote well-formed pathway looks like. How do you use these combination of open standards to create a pathway that is shareable, that can be consumed by this software, and that can be executable? That's what our community is about, and fostering and enabling that within the healthcare sector. The authoring work group is looking for those patterns. So as they look at those early adopters of BPM Plus, what challenges did they run into for a particular pathway? If they had a decision point and they were trying to assess which language was the best to use in this particular situation, what's the approach to doing that? For those that have a software background, you might be familiar with the pattern language discipline that evolved from classic architecture and Christopher Alexander. Those patterns kind of, it's that in that same spirit that this work group operates, identifying common patterns, repeatable kind of metaphors for problem types, and how do you approach them using these languages to effectively model them consistently and make them easier to understand and effective. That's what the authoring group is about. The use of those patterns to create specific pathways is up to the members, and members can make their pathways available for free. They can sell them commercially. They can do something in between. That's for organizations to decide. And as a community, we're not endorsing or recommending a specific pathway. Our limit would be whether something is correctly expressed in the notation or not. The next work group is the organizational adoption and change management. And those folks are focused on, let's say there is a new hypertension management protocol. How do I make that work for my organization? How do I bring it in? How do I train the staff? How do I configure the IT? How do you actually take this thing from something on paper to something that's working, with real people? And that's what this work group is about. And there's a really good session on one of their artifacts that's going to be tomorrow. The process automation and enablement work group is about the implementation side of this. So at present, they're focused on creating a reference implementation based on e-consent. So looking at advanced care planning and how do you realize and implement these approaches in working software. How do I create a model? How do I serialize that model? How do I bring that model into an executing system? How do I make it run? That's what this work group is about. Both creating the reference example so developers out there can understand what to do, and understanding what the thorny issues are in the implementation that would affect, the authoring and all these other work groups. The methodology work group is looking at the core expression languages and their fitness for purpose. So they've identified a few gaps. For instance, how does data interact with process? And how do you do that effectively so that when based on a certain lab value, we do this or that? And how do you model that? How do you interact those components as data intersects with process? So they identified a gap, and they're closing that gap with an emerging specification called the Situational Data Model Annotation, SDMN. So that's what methodology is about. And then finally, we've got the academic and professional education. They're working to establish curriculum so that as people formally train in informatics, BPM is part of the curricula. Working on workforce development, for instance. They've entered into a set of activities with master's capstone students in informatics programs that are using BPM techniques to do their capstone project. So that's really exciting, and there's a session on that tomorrow. So that's a really quick tour. Each of these work groups has a set of co-chairs. They've got a dedicated space on the web. They've got their own kind of set of priorities and agenda items. And all these groups are open. So if any of these strike an interest, you can join any or as many of those as you'd like. So I'd like to spotlight a couple of items. This is not intended to be an exhaustive list, so think of this more as a teaser, but I did want to call out a couple of examples of things that I thought were relevant. One is the Advanced Directive e-Consent reference implementation. So there's a new community forming in the advanced care planning and e-consent space. They are looking at how do we more consistently represent, for instance, patient wishes, not only in terms of expressing what those are, but in terms of being able to share those across systems and health systems. So this is a real problem. It's been amplified with COVID, but it's a real point of pain. And what the PAWIG, the Process Automation and Enablement Work Group, is doing is using this use case as an exemplar to show how BPM can be applied to this problem space. And in so doing, illustrate to the developer community and others kind of how this intersects with some of the areas that they know and some of the problems that are out there. There's a deep dive on this session on Thursday at 11 Eastern. The BPM Plus Adoption Playbook. So I kind of alluded to the organizational adoption piece. They've been working on this playbook. How as an organization, how ready am I to take on these emerging practices? How do I bring them in? How do I assess whether I'm ready to do that? How do I do the training? All those kinds of things. So they've created two artifacts to help organizations with that. One is an assessment maturity model, which lets you stratify, like the HIMSS maturity model or the CMMI maturity model. Level 1 is immature, level 5 is very mature. Where do I sit, and what are the things that I need to look at? And then the playbook side of it is, what do I do about it? So if I find out that I'm immature in a particular area, what are the best practices to getting senior leadership buy-in, to piloting a program within my organization, to approaching training, all that kind of stuff. And that's really what the playbook is about. So there's a deep dive on that tomorrow at 11 Eastern for those interested in this. I've alluded to some of the gaps in the notation space around these core set of standards, the three specifications around which BPM is built. A couple of those examples are the pedigree and provenance model annotation. Oops, that should be model annotation, my mistake. PPMN and the situational data model annotation, SDMN. Both of these are emerging specifications. The standards development process or adoption process is underway now. So if you're interested in that, the methodology work group can help you. I should note that while the needs were determined in the BPM community, the standards work is not happening in the BPM community. We're not a standards organization. So that is happening under our parent, under the OMG, in their technology adoption process. And we have our methodology work group as the link with the OMG community to see that our needs are met as the standards move forward. And then the final kind of exemplar is this COVID Navigator, which is not specifically BPM. It's a product of our community because we wanted to be good global citizens in and during the pandemic, and have been working on just applying our informatics expertise to the COVID problem to try to help provide some tools to help caregivers make informed decisions as these moving target of medical knowledge around COVID continues to evolve. So if you're interested in that topic, this has all been done pro bono, and that activity just hit alpha. So we're in an alpha test of that kind of portal. And we're looking for folks that are interested in kicking the tires and giving us your impressions and helping advance this to be a global asset. So that's Wednesday at 3. So 5 things to know, and I'm running quite ahead of time. Let me pause before I get into the 5 things to know. Any comments or questions? And I'm going to sit until I get at least one person to say one thing. No takers?
We can't let everybody sit and wait, Ken. It's an exciting endeavor that you're putting together here. So anyway, I'm just learning a lot as we go along here, so I appreciate that.
Thank you, Ed. I knew I'd get at least one person off the fence. These things, and part of the reason I'm kind of harping on that a little bit is the whole point of the community is to be interactive. So I know that this is kind of more of just a droning slide deck, but I'm a firm believer that in these communities you get out what you put in. So I really encourage folks to roll up the sleeves, to get involved, ask your questions, and I think you'll find that as a community we're very receptive to that. And we definitely want to hear what you have to say, and we want to hear your problems so that we can work together towards solutions. Any other comments before I move on?
I'm going to throw in a comment, Ken. So this is Denise from the OMG staff, and I don't always get the opportunity to sit into these meetings because I'm registration. So it's very exciting to me to see what's happening, and I'm blown away by the amount of work that's happening. And I don't find it droning. I find it amazing.
Oh,
So
thank you. Very kind. All right, I'll press on. I see Dr. J is off mute. Did you have a comment, Mark? He's probably muted elsewhere. All right, so 5 things to know, and I've given this type of a talk many times, and I'm still trying to continuous improvement. It seems like kind of picking a top 5 rolling things, based on where we are at the moment, has worked pretty well. So again, there's so many activities. Any one of our work groups has half a dozen balls in the air, so it's really hard to kind of raise it up 50,000 feet. But so 5 takeaways for all of you for this point in time. Participation is open to all comers, and we need to do a better job on the website of making that clear. One of the challenges I think that all of us have, we're all being pulled in 1,000 different directions. And speaking from past hats, most of my career has been spent in large organizations. I was with the VA, which is a massive federal agency in the US. I was with a global systems integrator, huge company, global presence for many years, actually almost 20 years. And one of the challenges that I see again and again is you have these internal individual leaders that get excited about an activity, and the organization might not be ready, or maybe the organization is ready, but it takes a while to kind of convince them to formally jump into the pool and engage. And I was really concerned within BPM that we not cut off those folks, because you might be an internal advocate, and it just takes 6 months to make the business case to engage your respective organization. So we have very deliberately created a participation tier that does not require membership, and that's open to anyone that's interested. Now, That said, there is value to being a member, and we're not looking for participants for life. But if someone's stuck in that position for some extended period of time, we're not cutting you off. We're not giving you the full benefits either, but you do have an ability to engage. Our call calendar is on the website and it's public, so you can go to our website, choose participate, and then the call calendar is there. Every call for the community is listed there. You can click on the call and you'll see the web information and the dial-in information, and you can just show up. So you could, this week, a lot of the calls are canceled because of the workshop, but starting next week, you could pick any of those calls and just dial in and say, hey, this is me. I'm interested in what you guys are doing. In addition, and I'll talk to the tooling in a minute, but we've got some community infrastructure, and we're allowing participants a time-limited use of all that infrastructure. So members have use as long as you're a member. Participants get 6 months of runway. I think it's actually 3 months of runway to use all those tools, really without any questions asked. So you can kind of get a feel for that. Now, at some point, we do have to limit the engagement of the participants at some level, so there is a member benefit. But we're not going to cut you off from the calls. We're not going to cut you off for contributing. There's a participant agreement. It's a one-pager, basically. And that says that you're going to be a good citizen. You're not going to contribute poisoned IP and come back and sue the community. So your contributions are being done in good faith, and that, to the best of your understanding, they're not patent infringing or anything like that. But it's a very low bar. So we'd love to see you start to engage. And all the products of the community, the field guide for pathways, the adoption playbook, those are free, and our intention is to keep those free in perpetuity. So you don't have to be a member of the community to use any of our stuff. So if you're one of those folks that just wants to go do it and you're not really interested in helping the sausage making, you just want to go consume it, you can do that. You can download this and do that. And that's true with much of our educational materials as well. That's all available. The second kind of key takeaway, things to know, is that we're focusing very heavily on high impact collaborations. We've entered into a strategic relationship with Integrating the Healthcare Enterprise, IHE. IHE was kind enough to give us an education track at their most recent Connectathon event, which was a few weeks back, 3 or 4 weeks ago. They gave us, I can't remember, 4, 6, half a dozen sessions. And we're going to be working very closely with them as HIMSS comes up. So we will have presentations in collaboration with IHE as part of the Interoperability Showcase at HIMSS and other venues, webinars, et cetera. So we're very, very excited about that relationship, and want to give a shout out to IHE for engaging with us. I've already mentioned the e-consent activity. I didn't mention that there's an emerging community coming together around that topic. So how does the advanced directives, advanced care planning community really start to work together? There's dozens of initiatives, if not hundreds of initiatives in this space. And there was a workshop a few weeks back, which to me made it clear that not only is there a burgeoning need, but the different parts of the elephant aren't necessarily joining up to form an elephant. And without a community to kind of bring the different players together, that's going to be a real challenge. So we're excited about what's happening in that space. We're going to be good contributors into that community, and we look forward to their success, and we want to do our part to help that group along. We are in the process of moving from tactical to strategic. So I mentioned that we were formally chartered in 2019 in September. Part of the on-ramp for our community of practice was to make sure that we had a sustainable long-term vision. And part of that was putting the bylaws underneath the community so that we're open and egalitarian the way we were talking about. That's been done. Those were adopted unanimously and instituted on January 1. So we're now operating under those set of bylaws. And in the bylaws, we created a steering committee, the strategic group that's focusing on the long term. So right now, that committee is empty. There's no one on it. Once the co-chair elections are complete, we will then focus on the steering committee, and that's where our community roadmap will be developed. It'll be developed by the steering committee and then ratified by the broader membership. That's where our strategic initiatives and objectives are going to come from. So we've had the work groups working loosely autonomously so far. There was cross collaboration happening, but it was more organic, and it wasn't deliberate isn't quite the right word, but it wasn't engineered. And as we evolve as a community, we're going to start to bring those threads together toward a shared execution. And that's the stage where we are now, and that's the priority for 2021. Community tooling is coming. So we've got some base tools already. We've been using Confluence for workgroup support. We've got web sharing tools and so on. We have access to some vendor products that vendors have been kind enough to make their modeling environments available to the community for use on community assets. So this is not for proprietary project use. This is to advance, these reference implementations and so on. We have been lucky enough to recruit in Jason Smith, who is the OMG technical director, to chair a tooling work group, which is focused on a couple of, actually, it looks like it's 3 channels of focus under the community tooling. So one is the community enablement tools. So how do we maintain the efficacy of our work groups and work together as a community? That's the first lane. The second lane is creating test beds. So how do we have an environment so a developer or a new product vendor can come in and start to kick the tires and see how they fit in this ecosystem? Having sandboxes available for people to play and so on is part of the roadmap and part of what's coming together now for non-commercial use, for community use. And then the third lane is kind of some sort of distribution channel. How do we take those that are building models, whether it's Mayo Clinic or the VA or the American College of Surgeons or whatever the case might be, and how do those get distributed and disseminated out to the people that want to use them? So we're trying to explore what the best approach is for that. So those are some of the lanes that's happening in the tooling. This is emerging as a priority. And the first tooling work group met about roughly a month ago. The last call had, almost 24 people on it. So there's clearly strong interest in this topic, and I expect this to be picking up steam as we move forward. And I guess the last thing to know, I've alluded to this, is the co-chair elections. This is for members only. So if you're a participant, you don't get to vote on the leadership, but members do. It's one organization, one vote. So regardless of organizational size, that voting is commencing this week. I don't know if it's open or not, but it's imminent if it hasn't opened already. And once the co-chair elections complete, we will be shifting our focus toward the steering committee. So that should be coming in the next meeting cycle, which is quarterly. So let me pause there. I didn't stop for questions or comments. Any comments? We're nearing the home stretch. So organizationally, I don't want to dwell on this. I'm not big hung up on org charts. This shows you the kind of current state of things as of this minute. Again, there might be some shifts after the co-chair elections. I expect there will be some. We're looking at potentially standing up another kind of industry ambassador liaison. I'm in discussions now, so hopefully we'll be able to make an announcement there. So we've got, ultimately, the whole community is accountable to the OMG board and the CEO, COO of the OMG. So that provides a backstop to make sure that everything being done is above board and clean. I focus a lot on that. I've been involved in some communities where there have been some shenanigans. So I bring this up just hopefully to reinforce confidence around that. So we're doing everything we can to maintain transparency. We have 2 sides of the house: the quote unquote staff side and then the community side. So let me start with the staff. The CEO of the OMG de facto heads that group, and then we've got 3 or 4 positions under that. Tracy Berardi has been our community manager since inception, but she has just recently left us to take a career opportunity she just couldn't pass up. And we're in the process of filling that kind of permanent community manager slot. We've got several folks from the OMG that are in the transition are covering for us. So we're in great hands at the moment. And we're looking forward to announcing who will be our kind of dedicated community manager. I serve as the executive director. This is an unpaid position, but trying to herd all the cats. And then we've got a chief health informatics officer, also a volunteer position in Shane McNamee. Shane is a rehab doc, spent many years at the VA, led one of their clinics around rehab, spinal cord injury, et cetera, for many years, and now is in industry. And wears a CMO or CMIO hat at a large company at Perspective. So this is the current staff side of things. So those are appointed positions through the OMG, and in the bylaws, those are ratified by the steering committee as we move forward. Then we've got the community side of things, and everything under the community side, in effect, are elected or are appointed by an elected body. So we've got our work groups, which are kind of the light teal here. We've already gone through those, so I'm not going to dwell on that. We can create new work groups as needed, and that would be under the authority of the steering committee. In addition to work groups, we have committees, which are intended to be either more transient or more operationally focused. So these are the folks working on the real content of the problem space. The committees are more keeping the lights on within the community. So for example, we're going to create a policy committee, which is going to come in under the steering committee, and that, we'll add a box here kind of thing. So right now, just to go over the ones we haven't talked about, I've mentioned we've got this kind of tiger team on COVID-19. There are two different efforts there, and we'll hear about one of those this week. We've got an ambassador program that's being led by Denis Gagné. Denis has done a wonderful job with the ambassadors. These are the folks that are willing to put on a BPM community hat and engage with new members, with speaking engagements, and are willing to represent the community, kind of setting aside their day job and focusing on what the community brings. So we're really thankful for that. Again, all of these are volunteer positions, and we've got about a dozen and a half ambassadors. People are vetted before they can wear the ambassador badge. We're really excited about that. One program they're going to take on starting soon is going to be a member satisfaction, kind of assurance program. So they're going to reach out to all the BPM members to understand, how well we're doing, where our improvement opportunities are, and get that feedback to us so that we can continuously improve. We've got a clinical advisory committee, which is led by our CHIO. And that's really kind of a nuclear group of all aspects of healthcare providers. So it's not just physicians. We've got nurse informaticians and others that are working in that committee. And that is a leveraged resource, really engaging across the entirety of the BPM portfolio to make sure that we can maintain and support that clinical perspective. That falls under the authority of the steering committee we've talked about. That's the community side. So again, I don't want to dwell too much on org charts. So this is really old. This is my bad. I forgot to ask the OMG folks to update this. So these numbers are, almost a year old. So forgive me for that. But even as of a year ago, before we just chartered, you had 2,700 visitors a month to our website, 2,500 people on our lists. We had almost 5,000 on-demand video views of our educational materials, and that number is going to be way higher now. We had, close to 1,000 downloads of the field guide, something like 35 member organizations, 17 ambassadors, 12 co-chairs, 5 working groups, and 2 COVID projects, and 1 collaborative community. And it's not a year since launch, we're a little over a year now. But that gives you a sense for kind of, where we were. Again, this was June, so, 9 months ago. So I think we've come a tremendously long way, and I think we've got a lot more way to go. So quick teaser for this week. I expect many of you have looked at the agenda for the week. At noon today, we've got a presentation on the consortium of consortia. So this is talking about the OMG. And then BPM has a little 5-minute segment there, along with several of the other managed communities. So if you're kind of interested in how the sausage making works and how these managed communities work, that's a session that might be of interest. And then this afternoon, we've got the 4-hour jumpstart. So again, especially for folks new to the community, this is a chance for you to get your hands dirty. Trisotech has been kind enough to let their modeling tool be used for the Jumpstart, and it's an interactive tutorial using some of these notations to actually do some modeling. So if you registered for that, you should have received credentials for the tool, and Robert Lario leads that and does a great job with that session. Tomorrow there are 3 sessions of potential interest. I've mentioned some of these. The 11 o'clock is the organizational adoption change management work group on their playbook. At 1:30, we've got the several of the case studies from these master capstone activities under our education work group. And then at the Alpha COVID Navigators at 3. And then Thursday, we've got the e-consent and advanced care directives reference implementation discussion at 11. And one thing I haven't mentioned yet, but I really would like to shout out, is the implementation showcase. So that's also being led by Denis from our ambassadors. And we've got, I think, 5 different presentations of folks that are doing real world stuff, implementing, based on BPM approaches. So that's more where the rubber hits the road, and a great exemplar. None of those should be product pitches. It's all about, people might mention their products, but it's really about how do you apply the use of these standards to solving real problems. So that's a preview of the week. I love this quote from Shane. The hardest thing to pick up in a sea of noise is the thing that didn't happen. And the reason I like this quote is BPM in this process, modeling and ultimately automation or partial automation, is about joining up different stakeholders across a journey. And as we can start to do that consistently and repeatably, we will know what things don't happen, and we will minimize that handoff risk between institutions, and ultimately improve the outcomes and the benefits to the beneficiaries of this care. So I thank all of you for making the time for this session. We've got a few minutes left for some open floor questions. Certainly please contact me if you have any questions or would like a deeper dive within your institution. We're happy to set up one-on-ones through our ambassadors to talk with you and your organization and figure out if or where there might be a fit. So with that, why don't I open the floor?
Hey, Ken, this is Ed.
Go ahead.
I think, one of the interesting things to me about your organization is the fact that there are a lot of competing interests in the organizations, and even just plain competitors that are going to be participating in these sessions and the whole BPM Plus organization. And I know that's kind of routine for you and a lot of your colleagues, but for some of us, it's kind of unnatural in a way to see competitors working together in a collaborative fashion. And I just kind of curious to hear from you how you sort of manage that dynamic, and the fact that competitors might not want to work in certain areas collaboratively, but in other areas they do want to work together.
That's a really great point. And one of the things, and this is where I've learned lessons from the OMG, and a professional mentor that I've had the good fortune to learn from. Once you acknowledge that everyone is participating in their self-interest, things get really easy, because I've got an agenda, you've got an agenda, everyone on this call has an agenda. Now that agenda might be to advance a public good. It might be an altruistic agenda. That agenda may be, I'm going to eat everyone for lunch and I'm going to end up as the last guy standing with my product. And that's okay. What that means is, as the community, my responsibility is to align self-interests. So it might be, and I'll pick on you, Ed, since you were kind enough to jump in, that you've got your agenda, but if you take this one little piece out, okay, then much of what you're trying to do, that one little piece is your secret sauce. And we don't want your secret sauce. We want you to be wildly successful in the market with your secret sauce. But the stuff that you got to do anyway, let's share the burden with everybody else. And I might work with somebody else to say, you know what, this portion of what you're doing aligns really well with what these folks do. So instead of you spending $1 on the dollar to go do this on your own, why not work with everyone else and reduce your cost by 95%? and then, by the way, end up with something that everyone can use, and you can still market differentiate. So it's my job to balance those things, and it's up to the co-chairs as well. And our co-chairs do a fabulous job of that. And that's why that infrastructure, that superstructure, going up to the OMG is so critically important, because if someone feels like they're not getting a fair shake, so let's say a co-chair isn't dealing with your particular concern terribly well, there's an escalation path to getting that resolved. But ultimately, when you acknowledge the elephant in the room, that there are collaborators and there are competitors in the market, but there's still a tremendous amount that we can do together. And that's true of us as a whole community as well. We're not trying to own the whole space. We're working with other bodies that are out there. We mentioned the terminology folks. We mentioned IEG. We haven't mentioned HL7, but we're collaborating with HL7. So there's all sorts of activities going on, and there's plenty of work to do. So how do we engage and do that effectively as a vertical? Great question. I think I have time for one more question or comment before we need to wrap. Great. Well, thank you, everybody. I wish you a productive week. If you have questions or comments about the community or anything that we're doing, please reach out, and we'd love to hear from you. And I'll leave you with, please get involved. If this is something of interest to you, show up on a couple of calls, decide if it's a fit. And if it's not a fit, that's fine. If it is a fit, roll up your sleeves and jump in. I think you'll find as a community, the group is very welcoming, is very engaging. And, we'd love to have we'll be better with you than without you. So with that, thank you to all the OMG folks for pulling together the logistics, and I wish you all a productive workshop.